All right, it's about that time. It's 8:30. So I'd like to welcome everybody. Welcome to the AMSSM Journal Club meeting. My name is Dr. Giorgio Negron, and I'm serving as the club advisor moderating tonight's Journal Club meeting. A little bit about myself. I'm a sports medicine physician at Memorial Healthcare Systems in South Florida, and prior AMSSM SMFC fellow class representative and an SMRC president. My background's in physical medicine and rehabilitation, where I completed residency at Emory University in Atlanta, Georgia, and completed my sports medicine fellowship in Mayo Clinic in Rochester, Minnesota. I want to share that the goal for the AMSSM Journal Club is to provide a national platform for student and resident members to present an article from the list of top 120 articles that sports medicine fellows should be familiar with. Our intent is to make this a fun learning experience to give medical students and residents mentoring opportunities with other AMSSM members while developing skills of reviewing articles and making PowerPoint presentations. We'll have two awesome presentations tonight. The format for the Journal Club meeting is that each presenter will be approximately have 20-minute block of time, and this includes a brief Q&A segment after this presentation. I ask everyone but the presenter to mute themselves during the presentations, and please enter your questions using the chat function, and during the Q&A segment, we'll ask the presenters their club mentors these questions. So I'm pleased to introduce our first presenter tonight, Dr. Maria Bianchi, and her club mentor, Dr. Mica Guzman. Dr. Bianchi is from Caracas, Venezuela. Currently, she is a family medicine PGY1 resident in sports medicine track at the University of Iowa Hospitals and Clinic. Before moving to Iowa for residency, she lived in Florida while working in sports medicine research and doing sports sideline coverage. She plans to pursue a fellowship in sports medicine. She's also passionate about global health, health equity, DEI, and advocacy. Her presentation tonight is on the AMSSM position statement for concussion in sport. I also like to thank Dr. Mica Guzman for serving as her club mentor. Dr. Guzman is a dual board certified in family medicine and sports medicine. His clinical practice, 100% sports medicine, is with the UT Health Austin, the clinical arm of Dell Medical School at the University of Texas at Austin. He's also the medical director of sports medicine and events coverage of the Musculoskeletal Institute at UT Health Austin, primary care clinical director at the UT Health Austin Sport and Injury Clinic, director of the Bone Health and Concussions Clinic, and the professional physician at the UT Austin Longhorn Athletics. Finally, he's also the official medical service provider for the Austin Spurs. Academically, Dr. Guzman is an assistant professor in the Dell Med's Department of Surgery and Perioperative Care, and courtesy assistant professor in the Department of Population Health, where he enjoys educating various resident specialties, medical students, and undergraduates pursuing a medical career. He earned his medical degree and his master's in biological sciences from the Drexel University College of Medicine, master's in business administration in St. Joseph's University, and completed his family medicine residency at Northwestern Magog in Lake Forest, Illinois. And finally, he did a sports medicine fellowship at Mercy Health in Wisconsin. All right, so now we turn it over to you, Dr. Bianchi. Start your presentation. The floor is yours.
Okay, 1 second. Can you guys see my screen well?
Yes.
Okay. So my name is Maria Bianchi. I'm a family medicine PGY1, and I'm gonna be covering the AMSSM position statement on concussion in sport. This was published in the British Journal of Sports Medicine in 2019. So for this, the AMSSM formed a writing group to review the existing literature on sports-related concussions, update its previous position statement, and address current evidence and knowledge gaps regarding sports-related concussions. The agenda for today, I will cover the background and purpose of the position statement, in general, concussion, definition, pathophysiology, and epidemiology. I will do that very briefly. I will mainly focus on diagnosis, management, the risks related to concussion, disqualification from sport, prevention, and then the conclusion. To start with the background and purpose of the study, of the statement, sports-related concussions is an important topic for sports medicine physicians, and there is a rapidly expanding knowledge base in this area. The purpose of this statement, like I said, is to provide narrative review of the existing literature and best practices to assist healthcare providers with the evaluation and management of sports-related concussions, and to establish the level of evidence, current knowledge gaps, and areas requiring additional research. The first AMSSM position statement on sports-related concussions was published in 2013, and this is an update to this statement. So what is a concussion? It's a traumatically induced transient disturbance of brain function. The clinical signs and symptoms of concussion cannot be otherwise explained by drugs, alcohol, medications, or other injuries or comorbidities. Regarding how it happens, it's not completely understood, but it has been characterized as a force delivered to the brain, causing disruptive stretching of neuronal cell membranes and axons, resulting in a complex cascade of ionic, metabolic, and pathophysiological events. Regarding the incidence, it is estimated that there are about 1.0 to 1.8 million of sports-related concussions per year in the 0 to 18-year-old range, and it's a subset of about 400,000 of sports-related concussions in high school and athletes. However, it is important to mention that the numbers are limited or not available for recreational club sports or activities of the youth and early adolescent athletes. So the main focus today will be the diagnosis and management. Regarding the diagnosis, it is challenging and it's based on clinical assessment. It is complicated by a lack of validated objective diagnostic tests, a reliance on self-reported symptoms and confounding symptoms caused by other common conditions. In addition, symptoms may be delayed in onset or initially unrecognized by the athlete. So for diagnosis, there are different settings when this can happen. The first one would be pre-season. And this encompasses the pre-participation examination and the development and practice of an emergency action plan. An initial baseline evaluation, including a symptom checklist, cognitive evaluation, and baseline assessment, has been considered best practice for all athletes by the NCAA. However, repeat annual baseline testing is no longer recommended for collegiate athletes. Common baseline evaluations include the battery of standard sideline assessment tests found on the SCAT-5, which we will go over later. And there are computerized proprietary neuropsychological tests as well. The other setting when this can happen is on the sideline, which is the primary endpoint there is to determine the probability that an athlete has sustained a concussion during play. If the athlete is deemed unlikely to have had a concussion, they can continue participation, and that should be safe. If when the athlete is brought to the sideline and evaluated, the evaluation indicates that there's a probable concussion, then the athlete should be removed from participation with no same-day return to play. It's important to mention that sports-related concussions are an evolving injury, and they should be severely reassessed when suspected. Especially like on the sidelines, once you start evaluating the athlete, if they clearly have a concussion, there's no need to continue the evaluation. Reasons for immediate removal and prompt evaluation include loss of consciousness, impact seizure, tonic posturing, gross motor instability, confusion, or amnesia. Concerns for more serious head injury include prolonged loss of consciousness, severe or worsening headache, repeated emesis, declining mental status, focal neurological deficits, or suspicion of significant cervical spine injury, and this should trigger the emergency action plan. For sideline assessment, the SCAT-5 is used, and the child SCAT-5 as well. They're recommended by the Concussion in Sports group for assessing suspected concussions. All tests should be interpreted in combination with relevant clinical information to arrive at the most accurate conclusion. Symptoms are the most sensitive indicator of concussions. The reliability of athlete-reported symptoms depends on accurate reporting, which can be affected by the lack of recognition of the symptoms or also by conscious false reporting to avoid loss of playing time. Here is an example of the SCAT-5. This one can be found online. You can have it on your phone and use it on the sideline. In general, this is a very extensive evaluation, so I'm not gonna go over every detail. But in summary, it's comprised of a brief neurological examination, a symptom checklist, a brief cognitive assessment, and a balance assessment as well. Another place when the diagnosis of concussions can take place is in the office. After the concussion has happened during sports. The office assessment should include a comprehensive history and neurological examination. There should typically be a clear mechanism consistent with concussion, characteristic signs, symptoms, and time course of concussion, and no other cause for the constellation of clinical findings. It is not unusual for symptoms, signs, and testing to normalize by the time an office visit occurs, in which case a visit should focus on recommendations for safe return to play, to school. If an athlete has ongoing symptoms at the time of the first visit, the visit should focus on excluding other pathologies and providing anticipatory guidance. And I'll be going over more in depth in the next slides. Other considerations that we should keep in mind is that there are other sideline evaluation tools that have been developed. However, these are newer technologies that don't have sufficient research to establish their utility. This includes apps as well that have been developed for the phone. At this time, helmet monitors, impact monitors, which are also being developed, are a research tool requiring additional study, and they're not validated for clinical use in the diagnosis or management of sports-related concussions. Regarding imaging studies, a head CT is rarely necessary in the evaluation of sports-related concussions, but should be used when clinical suspicion for intracranial bleeding or macrostructural injury exists. Regarding brain MRI, it is not commonly used in the evaluation of concussion, but it may have value in cases with atypical or prolonged recovery. There is also a new concept, which is the concept of clinical profiles. This is new. It is sort of to facilitate individualized management after the sports concussion occurs. So this sort of classifies symptoms regarding like the most common findings. So it says some people might have more vestibular symptoms, more cognitive symptoms, ocular, headache, migraine type, maybe more mood-related symptoms or fatigue. But these symptoms can overlap as well. And most patients have features of multiple profiles. How clinical profiles fit into the clinical care of sports-related concussions warrants additional research. Regarding management, sports-related concussion clinical symptoms typically resolve spontaneously, with 80 to 90% of concussed older adolescents and adults returning to pre-injury levels of clinical function within 2 weeks. In younger athletes, recovery may take longer. They may return to baseline within 4 weeks. Regarding management, there are certain aspects to take into consideration. The first one is the prediction of recovery. The most consistent predictor for recovery from concussion is the number and severity of acute and subacute symptoms. That is why it's important to take a good clinical history. Subacute headache and depression after injury are risk factors for symptoms persisting for over a month. A pre-injury history of mental health problems, particularly depression, appears to increase the risk for prolonged symptoms. Athletes with learning disabilities or attention deficit hyperactivity disorder do not appear to be at risk for prolonged recovery. Regarding treatment, the consensus guidelines endorse 24 to 48 hours of symptom-limited cognitive and physical rest, followed by a gradual increase in activity, staying below symptom exacerbation thresholds. It is important to mention that this has changed over the years. In the past, we would shut down the players completely, and that is not the recommendation currently. Further research is needed to define the role of prescribed rest in recovery. There is no human evidence that supplements like nutraceuticals prevent or improve concussion in athletes. This is an area that requires more research to guide future recommendations. Regarding the concept of persistent post-concussive symptoms, this means symptoms that persist beyond the expected recovery time, which would be 2 weeks for adults and 4 weeks for children. It is critical to understand pre-existing and coexistent symptoms and conditions in the evaluation for PPCS, since this might be confounding. It is ideal for those with persistent post-concussive symptoms to be evaluated by a provider or a multidisciplinary team with expertise in complicated concussion management. Regarding return to learn, school personnel should be informed of the injury and implement an initial school support plan without delay. Many concussed athletes recover quickly enough to return to the classroom with no or very brief adjustment of academic activities. However, the school should be prepared to provide additional support in case the athlete needs it. Early introduction of symptom-limited physical activity is appropriate. However, return to sport training activities should follow a successful return to the classroom. Regarding return to sport, like I said, concussion-related symptoms and signs should be resolved before returning to sport, and the return to play progression involves a gradual, stepwise increase in physical demands and sport-specific activities without return of symptoms before the final introduction of exposure to contact. There is a return to play protocol. You start like at the lower level, and then every time the athlete spends 24 hours without a return of concussion symptoms, they can progress to the next stage. Regarding return to driving, there's no accepted return to driving protocols. However, in athletes who drive, discussing the potential risks and harms is appropriate. Regarding the risks related to concussion, there are short-term risks and long-term risks. I'll start with the short-term ones. Continuing to play immediately following a concussion is a risk for increased symptom burden, worsening of the injury, and prolonged recovery time. Athletes who return to sport prior to full recovery are at increased risk of repeat concussion. There is a concept of second impact syndrome. It is both rare and controversial. It is considered by some to be a potentially life-threatening complication of re-injury during the initial post-injury time period that is not fully understood and appears primarily limited to pediatric and adolescent athletes. Regarding long-term risks after concussion, most studies determining the relationship of contact sports to mental health problem or depression later in life have low methodological quality and high risk for bias. There needs to be more study in this area, especially to understand the multiple variables. Regarding chronic traumatic encephalopathy and other neurodegenerative diseases, they have been described in former athletes with a history of concussion or repetitive head impact exposure, typically accompanied by behavioral change. The incidence and prevalence of CTE in the general population, former athletes with a history of concussion or repetitive head impact exposure are unknown. The most widely described risk factor to date is extensive exposure to both multiple concussions and repetitive head impacts, but the degree of necessary exposure is likely specific to the individual, and it's subject to multiple risk modifying risk factors. Subconcussive or non-concussive head impacts have been discussed as an entity apart from concussion history that may create risk for long-term neurological sequelae. Future research will depend on developing technologies that can assess brain changes following repetitive asymptomatic head trauma in humans. Regarding disqualification from sport, there are no evidence-based guidelines for disqualifying or retiring an athlete from sport after concussion. Therefore, each athlete should be carefully and individually assessed to determine the safety and potential long-term health consequences of continued participation. There is no set number of concussions or repetitive head impact exposures that should force retirement. And it is likely that athletes with higher numbers of diagnosed concussions will be seen in clinical settings as this condition is more known, recognized, and people are more aware of it. It is also important to do shared decision-making with the patients and their families, go over risks and benefits of continuing sports involvement to make an informed decision. Regarding prevention, it is ultimately more effective in reducing the burden of this condition than any treatment. And while primary prevention of all sports-related concussion is not possible, measures to decrease the number and severity are of value. There have been rule changes in youth soccer and football to reduce concussion incidents, and the effect isn't clear. However, there is evidence that practice modification and changes in tackling technique may reduce injury. Like I mentioned before, there are new technologies being developed regarding helmets to prevent trauma, but their protective effects for concussion are less pronounced. And usually what is thought is that players might feel safer with the helmets and might be more prone, and this would encourage a more aggressive style of play, potentially increasing the risk for injury. So in conclusion, sports-related concussion is complex, heterogeneous brain injury that typically resolves within 1 to 4 weeks, usually over 2 weeks for adults, 4 weeks for children. The diagnosis is challenging. It relies on self-reported symptoms, and this can be caused, that cannot be caused by other conditions, and there are no available objective diagnosis tests to confirm the diagnosis. After a brief period of rest, acutely concussed patients can be encouraged to gradually and progressively increase physical and cognitive activity while staying below their symptom exacerbation thresholds. In cases of prolonged symptoms, a multidisciplinary team experience in the diagnosis and treatment of concussion should be considered. Further research is necessary to better understand the potential long-term effects from concussions and repetitive subconcussive impacts, as well as incidence, prevalence, and modifiable risk factors. There are many beneficial aspects to participation in sport and exercise that should be balanced against the concern for concussion. And the AMSSM supports continued research in the area of sports-related concussions to enhance safe participation in sports. Thank you. I'm gonna stop sharing the screen now. Okay.
Awesome. Thank you, Dr. Bianchi. It's a great presentation. So before we go into any Q&A segment, Dr. Guzman, do you have any comments about the article and the topic about concussion?
Yeah, as Dr. Bianchi presented, lots of information in this consensus statement that I would encourage everyone to review time and time again. You know, the brain is complex in itself, and then injury to the brain it makes it even more complicated. The evaluations for this is certainly a baseline aspect for trying to do an evaluation either in sideline or post sideline event in the office as follow-up. And you can utilize a lot of the similar testing and baseline testing if you have that available for comparisons. Again, it's something that the more exposure you get to it, hopefully a little bit more and more comfort you get in every individual concussion that you evaluate. In this article, you know, as you can tell, does not provide a definitive aspect of you know, a diagnosis or what to do for the encounters that you may have, but it's a fantastic guideline and basis for an algorithmic approach, and I would encourage utilization of that. So yeah, I'm open to any questions. Of course, we can always spend times and times on concussion discussions, but for this moment, you know, anything that's directed to Dr. Bianchi or anyone else here, I yield the floor.
Thank you, thank you. I'll be checking the chat right now. So no questions here. All right, we got a question from Dr. Keller. Scat sticks or scoped?
So regarding SCAT6, I know at AMSSM this year, they talked about it. I believe there isn't enough research yet compared to SCAT5. So SCAT5 remains the one being used, but probably Dr. Guzman knows more than me in these new tests.
Yeah, I like how they continue updating the tools. That's one aspect. My team, we've talked about it. Everyone's more familiar with the SCAT5 and its utilization. So we personally use the SCAT5 in our evaluations, and then we have discussions as far as updating that to the SCAT6 and doing it on a more trial basis. We do the SCAT6 baseline in some of our high school students, kind of as a trial. But for evaluations, we're still sticking to the SCAT5. I'd certainly be interested in hearing what others have done.
Great presentation. Good evening, everyone. Just want to ask, is there any gender differences in the incidence and also the recovery rate from concussion?
So I believe regarding like that would be like the epidemiological part. There isn't that much like reliable information yet. So I believe that's the case. But maybe Dr. Guzman knows about that.
Sorry, my mute button was hiding. So, are you talking about recovery time frame in males versus females? That's the question.
Yes.
Okay. It's well, I guess so the short answer is yes. There has been a slight longevity in females compared to males. Now, is that statistically significant? Potentially not. I think it's. I don't recall the exact numbers, but it's like 14 versus 12 days. So if you fall within that 14-day recovery, as a patient, that 2 weeks might seem significant to you compared to 12 days recovery for males on that spectrum. But I tend to see it as pretty equal in that respect.
All right, thank you.
All right. Well, thank you for everyone for those questions. We're going to go ahead and start with our second presentation. I'm pleased to introduce our second presenter tonight, Dr. Karen Vaz, and her club mentor, Dr. Justin Chu. Dr. Vaz is a pediatric resident in Phoenix, Arizona. Her career interests includes pediatric sport activity injuries, injury prevention, sport nutrition, and advocacy. She chose this article because she is passionate about resistance training and has been resistance training since she was 13 years old. Her presentation is on the position statement on youth resistant training for 2014 International Consensus. Also like to thank Dr. Justin Chu for serving as her club mentor. Dr. Chu is a current fellow at the University of Louisville. His background for residency is internal medicine and pediatrics. He is currently serving as the leader of the Sports Medicine Fellowship Council, SMRC, representing the 2023 and 2024 Sports Medicine Fellows as a fellow class representative to the Fellowship Committee. Now we turn it over to you, Dr. Vaz.
All right. So article title for this one's position statement on youth resistance training. It's the 2014 International Consensus. No disclosures. And so just prior to diving into the article itself, just wanted to make sure everyone was on the same page on the verbiage I'll be using during this presentation. So per this article, I'll be referring to youth and young athletes inclusive of children and adolescents. And then training age will be the number of years they've been in a structured training program that's appropriately supervised. And then resistance training, sometimes colloquially, is called weightlifting, but we're kind of separating it out this time. So resistance training will be an activity where you're working against a resistant load. And weightlifting is the sport. And you may have seen this as like a clean and jerk or snatching. And then for the training they do for weightlifting, it's defined as multi-joint explosive movements that are very highly controlled and that require a high degree of technical skill. And then qualified professionals are people who are trained in the specific needs of youth in terms of their physiological, physical, and psychological needs, and have appropriate qualifications as well. So for youth resistance training, if they have regular participation from that young age, that reinforces positive health and fitness adaptations and actually has been shown to enhance sports performance as well. In terms of performance benefits, we've shown that there's increases in strength, motor and running velocity, the ability to change direction with a quicker speed, and also their increase in power production. In terms of health benefits, as many of y'all probably know, for body composition, there'll be a decrease in overall body fat percentage. In adolescents, it's been shown that they have increased insulin sensitivity if they do resistance training. There's also some psychological benefits I'll go over later. And now the World Health Organization does include resistance training as a part of the physical activity guidelines for youth. So in terms of muscle strength development, it's a combination of three main things. So muscular, biomechanical, and neural components. And so because of the pediatric article, there's progression obviously from childhood through puberty into adolescence. So what we would expect in terms of muscular strength development is that initially in childhood, there'll be more linear increases. However, in puberty, it can switch to be nonlinear and there's more rapid growth. And this is thought to be attributed to just maturation of the central nervous system, which enables the child or the now like pubescent patient to have better unit recruitment of their muscles, have higher frequency of firing, that have better myelination and are able to synchronize better. And then this continues into adolescence, so they keep on with the neural development. And then what changes will also be the increase in hormone concentrations. And the ones that are most implicated will be insulin-like growth factor, growth hormone, and testosterone. And then what was really interesting is that the number of actual muscle fibers itself is determined before you're even born. But what changes and what people notice will be that cross-sectional area, which will increase. And then also they will have a motor unit differentiation and a change in the muscle pennation angle. So there are several benefits. I'll be touching on the key ones. And so resistance training is thought to provide a good foundation for an active lifestyle. It's an important part of being able to have motor skill performance. So actually this article recommended that you would do resistance training prior to even participation in sports, so you can have that good foundation. And then as we discussed, the benefits for the like body composition, there's decrease in cardiovascular risk factors. And then there has been shown though that if you don't maintain it, that there's after a 2 to 3 month period, you will have detraining. So you'll kind of go back to your baseline. So it's recommended that's a year-round activity for the youth. And it's been shown for adolescents who are overweight or obese, which is a pretty significant number in our country. They're actually 2 times more likely to be injured in sports or physical activity. This is thought to be attributed to less ability to maintain postural stability and have less motor coordination. And it's thought that a psychological benefit for these patients, if they're able to start resistance training, will be a sense of self-efficacy, and that they'll be able to then improve on these pitfalls and then progress to be better performers in sport. And so this is an important part, I thought, because there's a lot of misunderstanding about resistance training in such young children. But it's actually found to be a very good time to start in childhood in terms of building bone mass and enhancing bone structure. And that if children are able to do multi-joint, moderate, high-intensity resistance exercises, it helps optimize bone mineral accrual. There's no, actually, there's evidence that's negating that there is a stunting of growth or risk of injury to growth plates, and actually found that it could be beneficial for the growth plates to have that mechanical stress on them. These are just some articles that I pulled out that have found some just different findings in athletes in particular. So for adolescent athletes who incorporate resistance training, they were found to have fewer injuries and also shorter recovery times. The second article was talking about how in female adolescent soccer players, the ones who, when they incorporated resistance exercises in their warm-up, they had a decrease in overuse injuries. The third article was talking about how there's a reduction in overall injuries and incidents in adolescent soccer players who also included resistance training. And then training that's focused on risk factors that are associated with youth sport injuries, so low fitness level and imbalances, that can be very good in potentially reducing overuse injuries by about 50%. Has been shown to have decrease in ACL injuries in adolescent athletes. And then also benefit will be enhanced symmetrical development of strength around their joints. This will help with their biomechanics, and then also improve lower motor competence, which allows them to have better control. In terms of injuries, so if there's no supervision, it's a too high of a load or inappropriate load, or the person instructing the youth is not qualified, this is usually the scenario where you will get injuries. However, studies have shown that most of these injuries are accidental or could have been avoided. Yeah. And then this article did mention particularly about young females about the benefits. So with pubertal changes, if they're you can develop abnormal joint mechanics if you don't have proper neuromuscular adaptation. So there have been several studies that have shown that with resistance training, you do get reduction in abnormal biomechanics. So one example will be decrease in knee valgus with landing, so less knock knee. Less injury rates, they have better movement mechanics, better posterior chain strength. And then in adolescent males, there's something referred to as a neuromuscular spurt, which is this increase in muscle power, coordination, and strength. And females who do resistance training from a young age have a chance of also having this neuromuscular spurt. For psychosocial benefits, there's actually not a lot of research in this field. However, some of the benefits are thought to be psychological well-being, self-image, and self-appraisal, improvement mood. However, they have to be engaged in their physical activity, has to be at their appropriate level, has to be something that they enjoy. And then there are risks of overtraining syndrome in this age, which is when you have a prolonged maladaptation of biological, neurochemical, and hormonal systems, and that can also have psychosocial implications. So making sure that it's not only at the level in terms of physical abilities and training age for that participant, but that it's something that they want to participate in too is important. And why? So for trainability, it's sensitivity of the youth to be able to respond to the stimulus and have benefits from that stimulus. As we all know, regardless of whether you resistance train or not, just naturally with age and development, like you will have improvements in your strength. However, you want to make sure if you're doing resistance training that you're providing the youth with sufficient volume and intensity of exercises. That way they're not getting stronger by virtue of just getting older. It's because you're also adding a healthy stress onto them. And kind of like I mentioned here, there's actually been shown that even children as 5 years old can have improvements in muscular fitness after basic resistance training, as long as you make sure the child is willing and able to do that at their maturity level. There's a meta-analysis that the article pulled out showing how actually children do show greater performance gains than adolescents in terms of enhancing their motor skill performance. And for children, it's more about neural adaptations. Once they get into adolescence, because of the hormones, it's the neural plus the cross-sectional area, as I mentioned before. And they actually do get strength gains at 34% after 2 to 5 months, which is pretty quick. And so for weightlifting, so the sport, we want to make sure that we base that on their training age, their competency in terms of technique, and then their maturity. And this sport actually has lower injury rates than other forms of resistance training and just sports in general. And so things to consider in this younger population will be equipment size. So because, like I mentioned in the second bullet, there's so many ways you can do. So body weight, free weights, machines, plyometric weightlifting. So if they are in, say, a gym setting, if you use equipment, making sure they physically fit onto that machine or adapting that machine to fit them or not using it at all. Making sure they have sufficient volume of exercise and intensity. So sometimes too, you can measure a 1 rep max. So that's just the maximum amount of strength that they can do for one movement. And in children, it's been shown that vertical jump, long jump, and hand grip have been correlated to their 1 rep max strength. It's not necessary to calculate this, but sometimes if you know what they can do for one rep as their max, you can then know if they're being pushed too much, where they're doing too many sets or too many repetitions, or if it's not enough for them because they can go further. So if someone has a low training age, because they're new to it, or they're just previously were sedentary, you want to start with low volume and low to moderate training intensities. Once they get their technique down and they adapt to those, then you can start to increase load. And same along with that, once they're competent, you can increase their sets and then increase their reps as well. In terms of recovery time, children recover quicker with fatigue-inducing resistance training compared to older ages, thought to be attributed to the muscle pliability. So usually for the children, 1 minute will be sufficient, but sometimes depending on that child, they may need longer time, so 2 to 3 minutes between sets. In terms of how often they should be doing this, a lot of studies have indicated between 2 to 3 sessions per week was optimal, but that this can progress in terms of quantity of sessions per week as they get older, especially if they then start progressing in their sport. And then something important to consider is all forms of physical activity your patient is doing, so sport plus resistance training, and then whatever else they may be doing. And then to help with injury prevention and to help with like overuse injuries, making sure that when you include resistance training, it's not an addition, it's in place of sport-specific training. And then in terms of like velocity, having a promotion of the intention to have quick movements helps with development of motor unit recruitment patterns and firing frequencies. And then you want them to move it as explosively as possible. However, you just want to make sure they have the appropriate technique at the same time. These are some key takeaways. So you want a program for patients that are going to be multifactorial, so that will improve the strength, the movement mechanics, and the functional abilities to help reduce sports-related injuries. And that you actually, it's been shown that you would want them to do resistance training prior to sports participation as a consideration. That way they have good foundations. And that if a child or a patient is inactive, that's actually a risk factor for activity-related injuries if they do choose to later do a sport. And if you know someone is wanting to do a sport, getting them proper training early on and a training prescription that focuses on their needs, abilities, and their deficits would be optimal. And then not having resistance training be in addition to their sport, but having it be in lieu of their sport-specific training events will help with injury prevention. And then encourage them to do this year-round is also highly encouraged as well. The article citation, any questions or comments?
Dr. Vaz, that was a great presentation. So before we head over to the Q&A segment, which I believe there was a question there, Dr. Chu, do you have any comments about this article on the topic of youth resistance training?
Yeah, I just want to echo what you said, Dr. Vaz. Was awesome with that presentation, sharing that information, synthesizing another great consensus statement, especially from the pediatrics world, which sometimes is, like you even alluded to, under-researched in the world of sports medicine. Some of the things that I really took away too that you touched upon is the importance of resistance training in youth, because the article emphasizes a lot as the neuroplasticity is commonly cited in this article, based on the amount of kids and the neurons and all the neuro anatomy and physiology of those fibers and the connections they're making with the neuromuscular junctions being able to be adapted with the resistance training at a young age is only more beneficial going forward. So that's one thing that I just want to make sure that people took away from it. And as well as like the importance of supervision. Obviously, you don't want to get kids who are really young, not because they reference technique being one of the major competencies before moving on, and like she mentioned, the frequency and repetitions, but making sure that they're supervised and progressing appropriately. So those are the things that I just wanted to finally add. But again, excellent presentation. But I'll let the Dr. Negron take over with the monitoring with the questions. I answered one of them, but I'll let you take over.
Yeah, I'll just echo on what the chat was saying. Dr. Troxler was saying that in peds, in the pediatric population, does the number of cells increase, or does the size of the cells increase in resistance training? Dr. Chu, why don't you just kind of voice what you're saying?
Yeah, so thanks for reading the question. So based on my understanding with the reading, it is fiber cell size and not the number of cells. And I don't think that's any different in adults. That's what this article focuses on, pediatrics. So that's what I mentioned here. And I haven't done any more reading outside of this article, but as a large consensus statement on the references they had, I think this was a great resource.
Yeah, and they also mentioned that it's actually the number is predetermined, like before you're even born. So it's the only thing is the cross-sectional area that increases. That's what you see in terms of like increase in size.
Awesome. Great, Dr. Vaz. Yeah, honestly, the biggest takeaway for this article for me was that in the injury risk prevention in the pediatric population is going to be key. Like correcting the technique, making sure that they're not going to hurt themselves. The fact that there's a lot of positive findings for psychosocial development, and specifically for the questions that the most debunking the biggest myth that you see for a lot of patient parents, that it's resistance training and stunt their growth. And that was really nice reading. So I would like to thank our two presenters, Dr. Maria Bianchi and Dr. Karen Vaz. I'd also like to thank tonight's club mentors, Dr. Mica Guzman, for serving as Dr. Mica Guzman for serving as Dr. Bianchi Club's mentor, and Dr. Chu for serving as Dr. Karen Vaz Club mentor. I'd like to thank everyone for attending tonight's AMSSM Journal Club meeting. It was also my pleasure serving as the moderator for tonight's Journal Club meeting. Our next AMSSM Journal Club meeting is scheduled for Tuesday, December 19th at 8:30 p.m. This concludes tonight's meeting. Thank you, everyone.
Bye,
Thank you.
thank you.